Hi, everyone. It's Dr. Verdialis from the Georgia office. So today, I like to pick a subject and start there and let you guys do the questionings that you might want to. So today is about what's on the other side of the rainbow. So what do I mean with that? I mean, a lot of you have been on a very long journey to motherhood, um, a lot of questions. What happens when you actually get pregnant? What happens on the other side of the dream? Um, and one of the reasons that I wanted to talk about this is I get to see some of my patients, fortunately, after they have their babies, and I get to see the happy sides and the not so happy side. So this morning, I had to go in a little earlier to help one of our ladies because she lost her baby at 13 weeks. So after we had discharged her, there was no heartbeat on her second, when she actually transferred to the obstetrician. So I want to talk about two things. One, motherhood after 40, and two, what happens after you leave CNY and what to look for. Um, some of you have heard me talk about the importance of the vessel, which is, the carrying um, person, the woman that's actually carrying the baby. And it's so important that after 40, we're all fabulous and fertile and wonderful, but our bodies have lived 40 years. So we have to be a little extra careful. We tend to have a little bit more chances of complications, including preterm labor, gestational diabetes, gestational related hypertension syndromes like preeclampsia. So it's not over until the fat lady sings. So even after we discharge you, you're still a high risk patient. Just think how hard it might have been to get pregnant. So a lot of times what I see is that as we discharge our patients, um, especially the ones past 40 years, and we took all of this medicine to get you pregnant, and now we just discharge you to your regular obstetrician. And a lot of times they don't have the exposure to high risk pregnancies past 40 achieved by IVF with immunotherapy, and they might remove you from some of the medicine that might have gotten you pregnant and kept you pregnant till you actually were discharged. So we have to be kind of aware of these things. So a few little pointers. um, I usually recommend my patients to have uh, supplements, robust supplements, the whole entire first trimester. And why is that? Because usually about 13, 14 weeks is when the placenta takes over for the baby's needs. So you really want, even though a lot of times you get discharged from CNY at 10 weeks, you're not out of the danger zone yet. So you really want to support that pregnancy all the way into past that first trimester, and sometimes even past that second trimester. So if you are taking, the fish oil and vitamin D and prenatal and some of the glandular therapy that I put you on, that's why I usually will recommend for you to do it till 12, 14 weeks. Okay. Two, a lot of these pregnancies are achieved through a lot of immunotherapy. So you want to gently slow yourself down. And if you've had a loss at one point, you might want to consider a baby aspirin, Lovenox, and even some prednisone into the second trimester. Lovenox sometimes till or some sort of um, anticoagulation until third trimester, even if it's just the baby aspirin. And this is a big, big one, progesterone supplementation past second trimester. Um, Some of the patients that I have co-managed through the years, especially multiples, like when you have two babies in the oven, you want to really support that pregnancy all the way to 36 weeks if you make it. And I've talked about this before, but I can't be emphatic enough about supporting this pregnancy that was achieved through a lot of effort. Now, that's one, right? That's one of the issues that I want to make you aware of. You should be seeing a high risk obstetrician, so a maternal fetal medicine doctor, as well as your obstetrician. And hopefully, I know all of you cannot get access to a obstetrician that's familiar with this type of protocol, but hopefully you will be um, with an OBGYN that is familiar or is open to co-manage your care, especially if you had one of these, difficult to conceive pregnancies past 40. Okay. That's why, as lenient as we are at CNY, that's why we require a um, a medical clearance past 50. We had a situation earlier this year where we had somebody actually turn 50, um, you know, right between her IVF and her transfers, or her, she was using donor eggs, but and so it's very important that if you are 49, you should go ahead and get those clearance. It's very important that, especially in this age group, not all obstetricians will assume your care. I had a lady actually be pregnant at 45, and her obstetrician, because she got pregnant with twins, donor egg twins, and her obstetrician refused to see her. And then suddenly she's now, 10 weeks pregnant with a pair of twins, trying to figure out who's going to deliver her babies. So it is to your advantage, as much as you want to bypass a lot of the things to, one, get your medical clearance. We also had a 52-year-old go into congestive heart failure. Um, because it was too much for her body. She was also pregnant with twins. She ended up unfortunately losing the babies, but you want to get your medical team on board no matter how you look at it. And look, I feel 15. It is a higher risk pregnancy. You want to have your medical team on board, your medical doctor, give you clearance. If you need to see a cardiologist, go through a stress test if that's what's needed. Go ahead and do it. It is to your advantage. We're not trying to punish you. We're trying to make sure that it's safe for you to be pregnant. We want you to succeed. We want you to be pregnant, okay? But let's do it in a way that it's safe for you, for the baby, and that you don't have a sad outcome. So, imagine going through all of this work and just to lose the baby or the babies, okay? Which brings me to, you want to really make sure that, especially if you're using donor eggs, just do one at a time. It is already stressful on the body to have one. It is a lot more stressful to have two. And we're already dealing with a population that is at higher risk, like I said, with some of the pregnancy associated complications, especially if there's any predisposition in the family, or within yourself, depending on your size, your weight, your overall health. So we want you to be a healthy mama, because you bring a new life into this world. So you want to be there for your child. You don't want to, God forbid, be disabled or not be able to play with your kid when that child is 12, right? Or go to their games, or enjoy, upbringing that miracle baby, that rainbow baby that you so much seeked out for so long. All right. So you are the vessel, you are the mom. So be on that mom role, be the mom you want for your child. And the mom that you want for your child is healthy, fit, okay, can run, can play, can keep up with that baby. So a lot of us don't really think about what happens after the rainbow. What happens after the rainbow is that you have to be a rainbow mom. So we have to work on our overall health to be able to be that rainbow mom after you have the rainbow baby, right? So I want to bring that up for you guys. I always like to bring things from a different angle, to get you guys thinking. Pregnancy, especially if you've had losses, uterine surgery of any kind, you might want to use progesterone till 36 weeks. Okay, so that's my 2 cents for today. Let's see some of your questions. Can you do uh, a 3-day fresh transfer with a non-trilaminar lining? Okay, so yes and no. So what happens is you want to have a trilaminar lining all the way up to retrieval. Okay, you want to have a trilaminar lining all the way to retrieval. And what's that? A trilaminar lining means that your uterus has been exposed mostly to estrogen. The moment that uterus is exposed to a significant amount of progesterone, that lining is going to switch. It's going to engorge, and that is how it loses that trilaminar look and gets wider. And that is the progesterone effect, because estrogen makes the lining grow. Progesterone makes the lining thicken and plump up, right? So, if you had trilaminar lining all the way to retrieval, you can do a day 3 fresh. So with multiple losses, including one IVF loss, what is my chances of carrying my own child? It will depend on the overall scenario. See, why are you losing the babies? Is the only reason, and that's still debatable. The only reason that you could, not carry your own child is one, you have a uterine malformation where simply doesn't the cavity doesn't hold the baby. I've seen those scenarios. Sometimes with cervical insufficiency, a cerclage might suffice. Sometimes we just need to support the whole pregnancy with progesterone. That's one of the things that I was talking earlier. I've seen some ladies that they get taken off progesterone. Once they transfer to a regular GYN, and boom, they lose the baby because they're not making enough progesterone, or they need more progesterone to quiet. Because what does progesterone do? It quiets the muscle of the uterus so it does not contract. Okay. Um, let's say there's no reason found. Your uterus is completely perfect. So we need to figure out, is it completely perfect? Are we dealing with, chronic infection, inflammation, hidden endometriosis, adenomyosis? Is it a cervical issue? Do you need a cervical cerclage? Sometimes women will go through even abdominal cerclages, permanent cerclages, to give that uterus shot. Are your losses painful? That's very important, because if they're painful, that means that it's preterm labor. A lot of times women that have an issue with their cervix not holding the pregnancy, they start dilating pain less. So then, by the time they figure out they're in labor, it's like they're already having bulging membranes sometime in their second trimester or late first trimester. Are we dealing with a genetic disorder? Did you have genetic screening? This is a case that may be genetic testing on the embryos. It's all about risk and benefit. Maybe the benefit outweighs the risk. So I would have to look a little closer to your case and see what's missing. Is it a coagulation disorder? Is it an autoimmune disorder? That's why I was also mentioning, a lot of our patients, like we do a lot of immunoreproduction, reproductive immunology. So is it that your body's rejecting the embryo? Is it an autoimmune type of reaction? Do you need to be on an immune protocol? They're pretty robust. We've had patients go through what we call immune 4 all the way to having IVIG, which is, pretty hardcore stuff. So I would have to see what has been checked, what has been done, and what else do we need to check to make sure that you get pregnant and you stay pregnant all the way to term. Okay? Um, so, this is some of the challenges that I see all the time. And that's why with some of the patients that are my local patients, I tend to co-manage just because I know I've seen, unfortunately, that, some of us don't get to the other side of the rainbow and, end up losing the pregnancy, or end up losing the pregnancy, after discharge, second trimester or late first trimester. And sometimes that could be preventable. So remember, an IVF pregnancy is not completely 100%. Okay. Um, So, what I was saying before, we want to get to the other side of the rainbow. We want to get healthy. We want to get to the other side of the rainbow with our rainbow baby, and then we want to be a rainbow mom, right? So, it's very, very important to start working on your overall health. And there's so much on regenerative medicine going on right now, from manipulations in food. You've heard Dr. Kill talk about what works for him. It works very, very well. I think he looks amazing. I think, he's vibrant and, I mean, he said it, he feels better now than 20 years ago. So that's working well for him. It doesn't work for everybody. There is something called genetic nutrition. We are genetically predisposed to absorb and process foods depending on our genetic composition. I had the pleasure of doing a full panel a few years ago through a company called NutriSync. I think they changed the name, but essentially it gave me a full report on how I process foods, what foods I don't absorb, my genetic composition. I ended up being an MTHFR gene mutation carrier, which explained my personal family history and some of the ways I respond to medication in general. There are genes that actually are either predisposing to diabetes or protective. Locally for me, I have a protective gene, but some people, we are very individual, and that's how medicine is going to end up being individual medicine based on what works for you. And we are approaching a place where there's even genetic testing for which medication works for you, what type of nutrition you should have. And all of that together, it's called regenerative medicine, meaning anti-aging. Okay. That area in medicine wants to stay away from that word a little bit, just because anti-aging is associated with cosmetic, even though anti-aging uses regenerative medicine for youthful looking, but it's all part of the same thing. It's about long, youthful living. Okay. And if you're seeking that rainbow baby past 40, you need to work on yourself as well. We don't look past that. It's like, I need to get pregnant. I need to get pregnant. Okay. Now I have the baby. Can I be a rainbow mom? Can I be a rainbow dad? Right. So let's work on that. Let's work on getting you all healthy and ready, not only to have your rainbow baby, but also to be a rainbow parent. Okay. Well, very good. Thank you so much for joining me. I will be here next Wednesday again. If anybody has any particular questions, feel free to reach out, and have a great rest of your week. Bye-bye.